Welcome everyone to the 2025 Syphilis Solutions Summit. We're thrilled to have so many here with us today. I'm Jen Rogers, she, her pronouns, and I lead the Sexual and Reproductive Health program here at Child Trends. I also direct New Insights for Sexual Health, or NISH, a project funded by the CDC. At Child Trends, our Sexual and Reproductive Health program works to support people who provide care, who make policy, and lead in their communities. We share research, we offer technical assistance, and we create clear messages to help improve sexual and reproductive health services and information, especially in communities that have the greatest need. I'm also joined today by my colleague, Kayla Garcia, who serves as the Deputy Director for the project and will also serve as co-host this afternoon. We're so lucky to work alongside an incredible team. Their pictures are shown here, including Emma Pliskin, Ellie Quinteros, and Mason Stowers. Huge thanks to each of them for helping make this event possible. Next slide. And next slide. Okay, so today I'm excited to share that we designed our summit with really two core goals in mind. The first is to deepen our understanding of syphilis and congenital syphilis, including the latest data, why this issue really matters, and what's driving the current trends that we're seeing. And the second is to really learn from Arkansas's coordinated response and reflect on how similar strategies could be adapted to your own local or state context. Next slide. As I walk through the agenda, please feel free to share your name in the chat. But today, this is what to expect over the next 90 minutes. We're going to begin with an overview from our CDC colleagues who will share national data and trends on syphilis and congenital syphilis. Then we're going to be hearing from our featured speaker, Mallory Jayroe, who will walk us through Arkansas's approach, including specific examples of how they've used the data, how they've been able to really build partnerships and then implement responsive strategies. Throughout the session, you'll also engage in polls and chats so we can really learn what you're doing and what's working, what's not working, what's challenging, and where you might need to seek some more support. And then we're going to wrap up some time for questions. Please feel free to send those in the QA, and then we'll end up with a quick feedback survey. Next slide. Okay, so now I have the pleasure to introduce our next speaker, Mallory Jayroe. Mallory is the Infectious Disease Epidemiology Section Chief at the Arkansas Department of Health. She has nearly a decade of experience in maternal health, and the past 3 years, she's been really focused specifically on infectious diseases impacting pregnant women and their infants. I had the immense pleasure of hearing Mallory present earlier this year at the Association of Maternal and Child Health Programs, the AMCHIP conference. I was really thrilled that STIs were being featured in that space and even more impressed by Mallory's leadership and insight during that talk. She's doing really powerful work in a state with unique challenges. And I knew right away that we needed to bring her voice to the summit. And so I went to her right after the session and asked if she'd be willing to share her expertise with us, and she has generously agreed and is here today. So before I turn it over to Mallory, I just want to give you all a reminder that Mallory, and again, Kayla, my co-host, will be periodically pausing throughout the presentation to get your thoughts, so please feel free to participate. I also see that you're used to being in the chat, so please chat us any comments or questions you have. There's also a Q&A button, and we will be taking questions at the end of the presentation and trying to answer some of those throughout. And of course, any questions that we aren't able to answer, we will make sure that we get to them afterwards and for all the follow-up materials. Mallory, thank you so much for being here. Take it away.
Yeah, thanks so much. So next slide. So I first want to say thank you to Jen and the Child Trends. I think this is a very timely summit, and I just appreciate, the kind words that you gave me and being able to spotlight what we're doing in Arkansas. Because I've seen from the chat, we're all working in maternal health, STIs, and we're here to learn about congenital syphilis and syphilis in the United States. Next slide. So these are my disclaimers. Views expressed in this presentation are not necessarily those of Department of Health, and I have no financial interest to disclose. Next slide. So just kind of an overview. We're going to be talking about who we are, understanding congenital syphilis, what we're doing, accomplishments, and future endeavors. Next slide. So anytime I do a presentation at a national conference, I do have at least one person say, "Where's Arkansas?" So I cheekily always put a map up to show where we are, because we are a small state, but we are in the South. And in all seriousness, we are the natural state. We have beautiful state parks, a lot of scenery, and at the bottom, it is Little Rock. And if you can't remember Arkansas, have you ever been to Walmart? Walmart was founded in Arkansas. So if you learn nothing today, you learn that Walmart was founded in Arkansas. So that's something you can remember. Next slide. But one of the things I like to do when I set up a presentation is those who don't know about Arkansas, I like to kind of set the scene of what we're dealing with. So we have around 3 million people. 9.2% of our population is underinsured. We have around 825,000 people enrolled in Medicaid and CHIP. We also have a very rural state. We have a lot of rural areas, and of course, those areas are higher rates of poverty, obesity, infant mortality. We also have a lot of urban areas, but I always like to say, even in our urban areas, we have places that are under-resourced, and we are 48 in health. Next slide. So I started this position in 2023. I became the infectious disease epi section chief. And when I came over, I brought SetNet with me, and I'll go into a little bit more of what SetNet is later. But when I brought that over, I had about a decade of maternal health. And my predecessor, I was like, what's going on in the world of STIs, right? And she was like, we got to start focusing on congenital syphilis more than we have been in Arkansas. And when I first started exploring kind of our partnerships and what's going on, I really noticed kind of the silo between STIs and maternal health, right? You go to these maternal health conferences, we're talking about prenatal care, we're talking about substance use, mental health, low birth weight. Well, that's all in the same syphilis population as well, and these STIs. And so, what I wanted to do, and my biggest goal for today and throughout my time here, is really kind of explain why, maternal health should also focus on STIs and why STIs should also focus on maternal health, because it's all the same thing. And STIs, especially syphilis, congenital syphilis, is a maternal health problem. And I know a lot of people, I saw people introduce themselves. I know a lot of you know about syphilis and congenital syphilis, and you might be, more expert than I am, because of course I do want to get a disclaimer. I'm not an expert. I learn something new every day, but I really wanted to start this and ground us of what congenital syphilis is. Next slide. So it is sexually transmitted. It is a spiral-keat shape, which is important to know because its shape actually is why it can move so easily in the body. It also can be transmitted via blood, and there's different stages of infection. Next slide. I really like this picture because it kind of shows you the syphilis course of the disease, and you can see in the tertiary phase it can be 10 to 30 years, and that is not a misprint. That is true. But when you get to that 10 to 30 year, that's when we start developing ocular syphilis and neurosyphilis, which can have very bad adverse effects for the body, and we don't want to get to that point. Next slide. I could go on a whole presentation about just the mechanism of this infection, because I just think syphilis is such an interesting disease. But basically, all this is saying is syphilis is a low metabolic activity. So because of that, it can actually change its genetic makeup. So when it gets in your body, the B cells are attacking. It doesn't want to be found, and it wants to kind of stay in your body, right? So it actually can change its genetic makeup. And I just think that is so interesting, and something I learned a few years ago that I like to talk about. Next slide. So just some quick facts. Syphilis in pregnant women can cause things like miscarriage, stillbirth, or baby's death shortly after birth. And congenital syphilis is defined as anything under 2 years of age. And I like to highlight this and say it twice because I just think it's such an important statistic. And that is approximately 40% of babies born to women with untreated syphilis can be a stillborn or die from the infection as a newborn. So again, 40% of babies. And when I read that, you can kind of see why this is such a big maternal health issue. Babies can also be born with congenital syphilis. They have bone damage, anemia, enlarged liver and spleen. That's kind of a telltale sign that we see a lot, and other adverse effects. Next slide. So I will warn, I am going to show a few pictures of congenital syphilis. You can go ahead and put them all up there, the 3. So it is vertically transmitted. And so we have, down at the bottom, we have a mucus patch. But not all the time will babies be born with these symptoms. They can actually develop it later in life. So you can see in the middle, that's Hutchinson's teeth, and then a baby born with a rash. Next slide. These are, again, more pictures of babies with congenital syphilis. You can see the arm is like this, and that's because it's very painful for the baby to extend its arm. So that's another telltale sign that we see with babies with congenital syphilis. You can also see they outline the liver and the spleen, which is enlarged. The middle picture, you can see that has the mucus. That's another telltale sign. And then again, the last picture is the rash, as well as the baby again with the arm. So these are just kind of some pictures of adverse effects. But a baby can also be born just like this, perfectly healthy and no symptoms, and mom and baby are happy and healthy. I want to tell a story about a baby in Arkansas, and I do have to give a trigger warning that this will end in infant death. A few years ago, a baby was born here in Arkansas, perfectly healthy. Mom did good. She had a vaginal delivery. And, only thing that really happened was the baby was a little small. That's really it. At around 2 months old, the baby started getting some runny nose, but, mom said, hey, it was, my uncle got influenza, so that's probably what it is. 6 weeks, the baby started developing a rash on its bottom, and they thought it was a diaper rash. And so she went to the pediatrician, they gave ointment and things like that, and they sent her on. Next, the baby started not feeding very well. So they went back to the pediatrician, and again, instead of breastfeeding, we did formula. At 3 months old, the baby started declining. So the mom took the baby to the emergency room, and upon arrival in a rural hospital, the baby was admitted to our children's hospital. When the baby arrived at 3 months old, it was in complete shock. The diaper rash had gotten so bad. And when I say diaper rash, at this point, the baby had open wounds on its bottom about this big. Very painful. I have a picture, but I don't like to show it. So I just like to describe it. But the baby, again, when you showed the picture, the baby's arm was kind of to its chest too, or to its side. So again, showing telltale signs of congenital syphilis. But at this point, an infectious disease doctor had not been called. They had geneticists come, they had oncologists come, because they were for sure this was cancer of some sort. They ran all these tests and it was not cancer. So they're like, what in the world could this be? Doctor after doctor, someone finally said, let's call the infectious disease doctor in. The first thing the infectious disease doctor said was, has this baby had an RPR ran? And that is a test for syphilis. And in the craziness, someone had run an RPR, and the RPR was 1 to 256. And those who are not familiar with titers, that is very high. And at that point, a baby is very, very sick. So the ID doctor was like, hey, mom, did you have testing during pregnancy? And she's like, oh, I got all the testing I needed. Well, we called the health department. And unfortunately, the mom did not get tested. She got tested one time at 21 weeks. She did have some prenatal care, but most of her prenatal care was actually done in the emergency departments. And of course, at delivery, she had no test done. Despite the efforts of our children's hospital, the baby did expire. So this is a 3-month-old baby that was born to a mom that, if tested at delivery, could have stopped this death. This is why I put this up here. This is why I share this story, because this is not unique to Arkansas. If you look at the data, there are other states that had babies pass away, as well as stillborns. So I like to encourage people to understand when I come up here and I say we have to do something, I do mean it. This is an emergency and we have to use our resources to fight this disease. And we can prevent and reduce the negative impacts of syphilis with testing and treating. Next slide.
So this is just a quick first poll. We want to get a sense of, in your state, getting pregnant women tested for syphilis is, and there's different choices here. So from very challenging to very easy, or it depends, would love to have you participate in this poll.
Thanks everyone for sharing. It looks like there's a real split between somewhat challenging, somewhat easy, and it depends. For those who have it somewhat easy, we'd love to hear what are some of the things that make it work. And also some of the things that just make it challenging. So let us know in the chat, and Mallory will pass it back to you.
Thank you so much. And I would also say it depends, right? And I like some of those answers. So next slide. So testing methods. I always like to just kind of touch base and talk about the testing methods. So you have screening and monitoring, and then you have confirmatory. So our non-TREP test, which is the screening and monitoring, are things like RPR, BDRL, and then you do the titers to track treatment response, as well as the TREP test. A lot of times I see the TPPA, and then of course the test algorithms, you start with the non-TREP and confirm with the TREP, or you can do reverse sequencing with TREP and then confirm with the non-TREP. Next slide. So one of the first things we did, speaking of testing, the first things we did here in Arkansas was we passed a law in 2021 that it requires all testing of pregnant women in the first and third trimester, and if not done during prenatal care at delivery. Next slide.
And thanks, Mallory, for sharing about Arkansas's state laws. That's really powerful to know that you will have that testing level. And so our second poll is, are folks familiar with the laws regarding syphilis testing for pregnant women in their state? And great, most of you are at least very familiar, somewhat familiar with your state laws. And Mallory, back to you.
And so those who aren't familiar, it's always good to are interested in other state laws. This is just a QR code that will take you to the CDC to see other state laws. Next slide. So treatment. We talked about the testing. We kind of talked about the adverse effects, but what is the treatment? That is the miracle drug penicillin. So obviously you have different stages of syphilis. You also have different doses for treatment. Use penicillin for everything. There is another medication for syphilis, which is doxycycline, but pregnant women cannot take doxycycline. So if a woman is allergic to penicillin, you do have to desensitize them, and that can be done by a pharmacist at an emergency room. Next slide. So treating babies with congenital syphilis. We have to, again, treat them with penicillin for every 12 hours in the first 7 days, and then increase to 8 hours for 10 to 14 days of life. So again, this is 10 to 14 days in the NICU. This is traumatic for the mom and baby. And again, if the baby has been perfectly healthy and nothing's going on other than, the mom say wasn't tested during pregnancy, had a positive delivery, the baby might have had a titer as well, or one of the long bone x-rays, things like that. There's different tests to test for congenital syphilis. Then the baby's going to NICU. We've seen a lot of stigma with this because obviously the first question is, why is the baby in the NICU? But again, and the biggest thing with NICU is the bill. So that's 10 to 14 days in the NICU with getting medicine. Next slide. So we talked about the treatment. We've heard a story. And I think the story enough tells you why this is a public health emergency. Melissa showed kind of some national trends and really kind of showed already why this is a national or a public health emergency. But I want to kind of go in a little bit more. Next slide. So again, Melissa did a great job showing this already, and it just shows again that it has increased over the past few years when it was almost eradicated in the 90s. And then we are seeing some decreases, but I don't want us to, put our shield down yet, because I don't know, we hope that's a true decrease, but we still want, in my eyes, to see less than 5 congenital syphilis cases in your state a year or 0. Next slide. This is the status slide due to the fact these are reported stillbirths and infant deaths. So as an epidemiologist, I do think stillbirths are underreported due to the fact I know in my state it is not required to test the mom who has a stillborn for syphilis, but I know many states have. And I think Arkansas is starting to move towards possibly doing that for testing moms who had stillborns for syphilis. Next slide. So what's causing this rise? Like I just mentioned, it was almost eradicated in the 1990s. I'm sure if you look at some of the data at your own state, you can see that it started increasing around 2017. So what's going on? There's systematic issues, there's individual behaviors, and there's implementation issues. So we see stigma, funding, limited resources. In Arkansas, access to care, we have a lot of prenatal access to care issues with prenatal care, as well as we don't have good mental health services and widely available in Arkansas. We have providers not prioritizing sexual health questions. We also have inconsistent screening patterns, which we'll talk about a little bit later about missed opportunities. And then we also have things like drug use and hookup apps. Hookup apps are a really big issue right now because a lot of apps are anonymous, and that's what they're built for. And so if you get an STI, you might not know who the partner was or anything about this information. So that's been a challenge. Next slide. But as I go to talk about some of the risk factors involved with syphilis, I like to reassure people that syphilis can affect everyone. I know this is a silly thing to say, but if you're having sex, you need to be tested for syphilis. And that's kind of the mindset we want people to have, because we used to test women if they had a risk factor. And there have been multiple studies showing that, babies born with congenital syphilis around, in Arkansas, 60% had risk factors, but that 40% had no risk factors. And so again, we have to test everyone because syphilis can affect anyone, and it's preventable and treatable. So again, when we are messaging about syphilis, we want to focus on the risk factors, right? We got to address that, but we have to be careful with messaging because people might think, oh, they don't have those risk factors, I don't need a test. And that's not what we want to be sending. Next slide. So now we're at the Arkansas syphilis crisis. Melissa showed data for the national side, and I'm going to kind of show just what we're seeing in Arkansas. Next slide. So again, this is back when I first came on in 23. I just wanted to show kind of the first thing I saw when I took this position. And this was the 2022 surveillance report. And you can see the US rate and Arkansas rate, and see the US rate went up, but so did Arkansas. And Arkansas has always been higher than the US rate. And we've always ranked around the top 10. Next slide. This was one of the first graphs that we looked at. And this was just a 10-year between 2012 and 2022. And you can see there was a 560% increase. And as Melissa said, nationally, there's like a 760% increase. So these arrows you can see around 2018, that's kind of when we saw our first spike. And the CDC actually came to Arkansas and did kind of like a grand rounds and kind of talked with our ID branch and met and kind of started coming up with some strategies. But of course, 2020 happened, the pandemic, and all of our resources and focus came due COVID. Then in 2021, we were still vigilant in Arkansas, and we did the law. So now we're looked at missed opportunities because, like I said, we saw the data, we did the law, but we are still seeing some of these cases fall through the cracks. And so CDC actually was the first one to do this missed opportunities, but unfortunately they did not share their SAS code with us. So we kind of had to figure out how in the world they did this data. So this was kind of the first thing we did. And you see that one of the things we saw was no timely treatment despite timely diagnosis. And we'll kind of get in a little bit later what that meant. And then again, no prenatal care and no timely syphilis testing. Next slide. Now the CDC very graciously sends all the states, or at least I know Arkansas, sends them their missed opportunities category that they do. So in Arkansas, obviously, no, we don't send all of our data to the CDC, some of our DIS notes and things like that. So we have more data in your own state where you can do your own missed opportunities calculation. And so this was from the CDC. They've added a few more columns. But as we know, looking at these missed opportunities, there's so much more of the story than just this inadequate treatment or no testing. And so what we're doing here in Arkansas, we developed a red cap with the SETNet, and again, I'll get into SETNet a little bit later, where we're looking at our SETNet data and their missed opportunities, and we built a red cap. We actually just finished this week, and so I'd be happy to share once we kind of get that going and how we're looking at the missed opportunities and comparing it with what CDC has. Next slide. This was a paper, Arizona and Georgia actually did a paper similar to this. This was just a sample of our data, and we looked at congenital syphilis, non-congenital syphilis, and then broke it down by substance. Next slide. And this will be probably published a little bit later this year. And we did add missed opportunities to this. Next slide. And then we looked at social and behavioral history. Next slide. So what we found was high rates of substance use and reinfection. So 38% of our moms reported substance use, and that was mainly meth, cocaine, and alcohol, as well as 42 experienced syphilis reinfection during pregnancy. And what that means was they either had syphilis before pregnancy and was treated, or they were treated during pregnancy, and adequately treated and then reinfected. And that tells me we're having an issue with treating partners. There were common issues like mental health issues, domestic violence, and delayed access to prenatal care. This is SETNet data, and so with SETNet, we look at birth data as well as we follow the infants for 2 years. And so looking at some of that data, 28% of our infants were born premature, and 20% had low birth weights. And again, this is just a sample of our data. And on average, infants only had 2 to 3 follow-up visits after birth. So what this says to me is that there's an interplay between substance use, mental health, and social challenges. And to address these issues, it was going to require integrated trauma-informed care models that support both maternal and infant health. Next slide.
Thanks, Mallory, for covering these things. We're at our next poll, which is how Mallory just presented all of the data from Arkansas. Do you folks know how syphilis rates are trending in your communities as of today or the most recent year? Also, while we're waiting, seeing some great comments in the chat overall about the policy environments in different states, the gaps in kind of having those policies live up to their full potential. And also, I just want to point out Lauren's comment about this conversation between harm reduction staff and Title V staff in Virginia, and just kind of re-emphasizing Mallory's point that it takes a lot of people to provide adequate care, and that a coordinated response is something that we need to address this public health emergency.
Yeah, and you'll see in the next few slides of some of the partnerships we've had, because that's exactly what we're doing. We're trying to use our data, identify the partners we need, and then bring them in the same room.
Looks like by and large, everyone's still, or at least half are still increasing, and about a fifth are remaining stable, and some are decreasing. Next slide in the chat, if you also can include who provides you data about syphilis in your community. But Mallory, you can keep going with your presentation.
So at this point, again, we know the data, we know there's adverse effects. And so kind of going back to 2023, when I started this position, I was like, okay, we got to do something, right? We're public health professionals. The data is clear. There's been, national recognition that we need to do something. But as you see, there's always issues in public health, right? We're always faced with barriers. So back in 23, 24, we had a penicillin shortage. So then we started having to ration penicillin. There was funding cuts, right? That sounds familiar. And then there was also, in Arkansas specifically, we had a test tube shortage. There was also large cities having outbreaks. So that takes a lot of resources. Next slide. But we're public health, right? We don't just sit around and not do anything. We have to make a dollar stretch, and we have to think outside the box when it comes to coordination. So the next few slides, I'm kind of going to talk about what we're doing here in Arkansas. Some of our stuff is fleshed out, and we've been working on it. And some of our stuff, we are just now making new partners and continuously doing this work, because it's going to take any and everyone, and I'm sure as everyone who works in syphilis knows, or STIs, or really in public health, you solve one problem and another problem comes up. So it's just going to be continuation. So the first thing is obviously SETNet. So I'm the coordinator for Arkansas. And for those who don't know, SETNet is Surveillance for Emerging Threats to Mothers and Babies. It is a CDC funded program under the ELC grant. And it actually started not as SETNet, but kind of as a program with the Zika outbreak. And one of the things they learned was that they don't have a surveillance tool that really focuses on emerging threats to moms and babies. And so that's where SETNet was born. Arkansas did not come on until 2020, and we came on during the COVID-19 pandemic. SETNet now does CMV, syphilis, Hep C, dengue, and it's structured to adopt to any new emerging threats to mom and babies. So when I came on, like I said, I was doing COVID-19, and when I came in this position, I brought SETNet with me, and I asked my predecessors, again, what should we focus on? And clear syphilis was the answer. Next slide. I always like to shout out my team because I cannot do this without them. We have Alexis Sullivan, our epidemiologist, as well as Ayana Billings, who's our data manager. And we have Dr. Greenfield, who's an OBGYN. And as we know, funding is always tight. And so we built relationships during the COVID-19 pandemic when he was on our grant, and he loves SETNet and what we do. And so he graciously volunteers as our medical advisor and really helps us. Next slide. So this is kind of our timeline, right? back in 2021, we did do something during, all the craziness with COVID. We we did a law in Arkansas, but I'll tell you, though we did the law, not a lot of, providers were keeping up with the laws passed in Arkansas at that time. So a lot of things we were seeing was a delay that providers didn't know that was a law. Hospital systems didn't realize that was in place. One of the first things we did was do an internal steering committee because we had to get all our ducks in a row in Arkansas. So we had epidemiologists, STD nurses, program coordinators, and our infectious disease branch. With SetNet, when I started looking at the data and looking at kind of what was going on in Arkansas, I noticed very fast that the backbone to these programs are disease intervention specialists. So DIS, for those who don't know, do contact tracing. In Arkansas specifically, I say they wear all the hats. They're social workers, they're therapists, they're FBI agents because they can find a patient, let me tell you. But this just, I really saw a need and to really connect because I see the data, but talking to people who are working this is really important. So I did a survey to the DIS. I got really connected with their manager, talked to some of them. Some of my staff went out and kind of like Josh shadowed what they did to really understand what was going on. And some of their stuff was very valuable information. And then that relationship was super important. For funding purposes, ADH decided that we're going to use carryover from our COVID-19 SetNet to kind of support some of our syphilis efforts that we were doing. And then the SetNet group and the ID branch started looking for partners to address this missed opportunities in care because we saw that this was much bigger, right? We have drug use, domestic violence, mental health, moms not receiving prenatal care, as well as a lot of NICU babies. So we had to make partners, not just internally, but externally. Next slide. So some of the first partners we made was Bonnie Stribling, who was the Department of Human Services. She is a grant manager and a peer support specialist. So she was actually a mom who has lived experience. So that was super important for us to get. Dr. Heather Young, who is a disease doctor. She actually was one of the ones who treated the patient that I talked about earlier. And she's been a really big advocate for syphilis and congenital syphilis in Arkansas. And again, our great medical advisor, Dr. Greenfield, who's an OBGYN. Next slide. So when we had our meeting, one of the first things we looked at was our missed opportunity slide. I showed a few slides back, and I showed them about the inadequate treatment. And when we talked to the DIS, when we talked to our nurses, they said a lot of times doctors and providers are not understanding the treatment for syphilis, or they might do, oh, she just needs one shot and doesn't understand, no, this is latent, she needs 3 shots. And they just weren't understanding the testing as well. Like they just do an RPR and not a confirmatory and things like that. So one of the first things we did was we held a summit. We had a call to action because we also, in our talks with people, I don't think people understood what was going on here in their own state with our rise in syphilis. We picked 2 areas with our hotspots, which is Central and Northwest Arkansas. And at this provider conference alone, we reached 115 medical providers. We also recorded this, so it is on our healthyarkansas.gov website, and I can give a link to the chat at the end of this, so you all can, if you're interested to see in this summit. Dr. Young tells the story in more depth and more for medical providers in lens. So I think that'd be interesting to see. Next slide. But our Syphilis Summit didn't just stop at the 115 providers we reached out. Nurses started requesting presentations to their respective hospitals. More presentations were requested. One of the biggest connections we made was with the Arkansas Hospital Association, because you not only want to get the providers on board, you need to get the admins on board as well to make sure they know what's going on. And so when these policies are in place and we want to do new policies like I'm about to talk about, they'll already be on board. And the most thing I'm proud of that came out of our summit was our Arkansas Perinatal Quality Collaborative pilot. Next slide. So the director was at the Northwest Arkansas Syphilis Summit, and after we got done, she approached me and said, hey, I'm with the ARPQC. We're finishing up our C-section bundle. She told me what the ARPQC was, and she said, I want to do a syphilis sprint initiative. And so we got together with the Department of Health, myself, and the ARPQC, and we came up with our initiative goal, which was 100% of the birthing hospitals will implement universal screening for pregnant patients for syphilis during delivery hospitalization, so at delivery. You can see the link right there if you're interested in going to see kind of like all the stuff we're doing. They also have really good resources for providers and the public. And we also have it in English, Spanish, and Marshallese because we do have a Marshallese population in Arkansas. Next slide. This is just showing kind of how we started. We kicked off, they have a power workshop every year. We kind of like introduced the bundle to get people interested in doing it. And then they also had policy and practice recommendations that they suggested to the hospitals. Next slide. So we did a baseline, and due to time, I'm not going to get into kind of the data of it all, but if you're interested, I'd be more than happy to chat. And we are going to be almost finishing this up soon, and so you'll probably see us at conferences talking about some of the data and evaluation. Next slide. And again, just more baseline data. Next slide. So we're collecting this data, and we're collecting data now, and again, it's going to end in July, and we'll do a big evaluation of the data. But back in January when it started, we got started getting some media attention, and this was back in February. But we already saw, really good our progress with our testing everyone at delivery, because like I said, our law right now is just first and third, but we're trying out this test and delivery. And a OBGYN director at Great River Medical said, because we're initiated syphilis screening on admission, we were able to catch a positive case that was initially negative in the first trimester. By screening every patient at admission, we were able to get a baby in tertiary care for treatment. So again, they were working, and you can see that at this point we had 24 out of our 34 birthing hospitals in Arkansas. And when we asked about, why the other hospitals weren't on board, they said, oh, we don't have this problem. Well, you don't have a problem until you have a problem, right? And we want to prevent it no matter what. And so we're working on more education with that. Next slide.
Thanks, Mallory. And that is such a great idea to partner with your PQC, and I'm glad that they were able to get on board. We'd love to know how folks are thinking about partnering with their PQCs, if they've thought about it at all or have successfully partnered with other hospitals in their area. Mallory, we had a great question. I know it's not necessarily the question time yet, but since you've just talked about it, Jeremy asked, how did you get providers to come to your summit? And kind of like, were they providers outside of the typical STI norm who like haven't really thought about it since school?
Yes, so we use that internal stakeholder group to get providers to the summit. So we had nurses, we had our outbreak nurses who reached out to their contacts. They were a big advocate. So we had Dr. Greenfield, who has connections kind of all over the state. And we got not just OBGYNs, we had PCPs there, we had other public health professionals. We also had this thing in Arkansas called county health officers. And so we use them to kind of blast out the conference in their own community and kind of get the right doctors at the summit. So that's kind of how we got people where to be in the seats. And then of course we recorded it, which has been very beneficial because obviously we have rural doctors who can't leave, but they were interested. We had pediatricians ask for the recording, so we've sent that out. And then we just ended up putting it on our website for all providers to see.
I love that. And that's such a great sustainability piece to record a live event so that it is available for people who can't make it at that time. Great. We can keep going on to the next slide.
So again, we started the ARPQC, we've done the Syphilis Summit. Now, let's talk about the data, right? Like I said, we are a CETNES jurisdiction. We were funded for year one, and we're building up a registry because our STI program collects a lot of good data, but it kind of stops, you get all this data, and then when the baby's delivered, it kind of stops, and we don't really know what's going on after that. So that's where CETNET kind of does this enhanced surveillance. So we are building up a registry. We have data points from the CDC, but we also here in Arkansas have our own data points that we're interested in collecting. We do internal medical abstraction, and right now we're focused on births between 22 to 24. And so in Arkansas, that's around 623 mother-baby dyads. And right now we are happy to say we've completed the 2022 and 2024 births thanks to our amazing medical abstractor, Ayana. And so we're already starting to see kind of some evaluations of what our data is showing. So we take the STI data, and then we have this birth and infant follow-up data that we can see what's going on, past delivery, to not only babies born with congenital syphilis, but maybe babies that had a mom that had syphilis and they got that adequate treatment, but we still want to know what happened after the fact. Next slide. So remember these results, back to the paper. We had high substance use, reinfection, low birth weight, and our babies were not getting, pediatric care. So we took these results and we made partners out of it. Next slide. So one of the first things we did was, with our partnership with the DHS, they wrote us in their state opioid response grant. Next slide. So through the opioid response grant with DHS, one of our goals was to enhance the capacity of drug rehabilitation facilities across the state to provide testing and treatment services for pregnant women with syphilis and substance use disorders. We did an outreach campaign to the rehab facility. Our STD nurse is getting kind of like an STI toolkit for these partners. We have reoccurring meetings. And one of the biggest things that came out of this was their peer support specialist took our ADH syndemic testing training. So they got trained in HIV, Hep C, and syphilis. So that means these peer specialists can go out in the community on places we can't reach to do education and testing. And we've seen a really big benefit for that. Next slide. We also partnered with our American Academy of Pediatrics because, y'all, pediatricians are a key in this fight against syphilis and congenital syphilis. We had a grant from the National AAP, and here are just some things we're working with our chapter on. We're doing podcasts. We're doing a presentation at their steering committee in a few weeks. And our Dr. Young is doing the podcast, and they're doing like newsletters and things like that to get this out in the community. Next slide. We're doing social media, right? This is one of our Instagram posts, and this is just kind of like a cheeky, like, the swipe right, it's a date, and just knowing that testing is private and free at the local health units. Next slide. We also just made posters, and this talking about keeping them safe and when you're supposed to be tested, because we not only want providers to be doing this, we want women to be able to have knowledge of this and advocate for themselves if they're not being tested. And then we just have another poster. Next slide. So thus far, this is our social media breakdown. We had March, April, and May. This is our reach and our links clicked, and this is done gracefully by our Arkansas Academy of Pediatrics team. And so they kind of keep up with this breakdown, and they provided this to us. Next slide.
All right. Thank you, Mallory. These are some great partnerships, and I think really helpful to understand the breadth of people you could connect with to get the word out, not only to have providers really understand what they should be doing, but even patients being able to advocate for themselves, like you said. So just in the chat, if folks can share who you could partner with to get the word out and what kinds of messages you'd want to send related to syphilis for your state, that would be great. And we can go on to the next slide. And we're getting close to, I think, questions too.
So this is the big one, right? We talked about the data. We talked about the adverse effects. We talked about kind of some things we're doing here in Arkansas. Now, this is the biggest thing, right? I think every state struggles with is getting clients to the door for testing. Next slide. So some of the things we're doing on top of all the other things, our pilots and things like that. So I kind of want to talk about the structure of Arkansas Department of Health that kind of can help other states see what we're doing. So we are a centralized structure. So we are, we cover the entire state of Arkansas, and then we have local health units. So we have 94 local health units in 75 counties. Our DIS are housed in local health units, which is very beneficial because they are a part of the community. They kind of have, they're kind of like stakeholders in their own community. And if they're at the health department or at the local health unit, if they're on a phone with a mom and she needs treatment, they can walk down the hall and say, hey, we need to get this mom in right now. And it's been very beneficial having DIS housed in local health units. We also have 2 congenital syphilis DIS. We have an STD nurse who does training for our health unit staff. So our make sure our local health unit staff is also trained and up to date with everything. One of the things we do is when we go out for partnerships is we're able to offer 340B pricing. So that's just lower drug cost. And that has been beneficial to some of our partners. For example, where we're currently working with Armor, which is they got money to have a van to kind of get in places where there's high drug use. Where they're going to treat people who use substances who may not be going to the doctor, and we're trying to leverage 340B pricing. So then we can kind of advocate with them to do testing and treating in the community where places we can't get to. One of the biggest things that we did that I think has been the most beneficial is intertwining our branches within the health department. So we have really worked closely with obviously the infectious disease branch, epidemiology branch, and maternal health. So intertwining those people, getting them on the same table has been very beneficial to kind of see like, oh, we have these resources, oh, we see this, and so forth. As Melissa mentioned, with the task force, they released different to other funding sources that they can use funding for syphilis outreach. And so we partner with the Title V, and then also SAMHSA sent out a letter too. So that is where we kind of worked in the opioid state response. And we're kind of working with Title V with the needs assessment and making sure they have syphilis in their needs assessment to address that. Next slide. One of the other things we're doing is a point of care testing. So a lot of states have done this. Louisiana actually did this, and that's kind of where we got the idea from. And this point of care testing, the idea is that if a mom comes in a local health unit, she's there for prenatal care or just to get a pregnancy test, we're testing this mom, and if she's positive, we give at least one shot of penicillin. This is just going to be a pilot for 3 to 6 months. And again, we're testing pregnant moms and people or women coming in for a pregnancy test. Next slide. So policy. This is a big thing that I think we kind of forget about when we're doing community outreach is how policy can help. So again, we mandated syphilis testing for pregnant women. In Arkansas, we have reporting requirement. So you have to get your positive syphilis test to the health department within 24 hours. We have free testing and treatment services within our health units. And then overall, our leadership is very passionate, and our state epidemiologist is passionate about addressing congenital syphilis. So that gives opportunity for them to go to the legislators. We've made one-pages for our legislators to kind of get them on board of kind of addressing congenital syphilis. Earlier this year, our governor unbundled the Medicaid expansion, and so that opens up possibilities for more prenatal care and, again, testing and treating. And the biggest thing we just learned about was actually at the ARPQC steering committee meeting. Arkansas Medicaid is on that steering committee, and they announced that they're going to launch new performance measures incorporated in longstanding IQI, which is Inpatient Quality Initiative, in July, focused on syphilis testing during delivery admissions. So again, I just want to remind you of the progression. We saw the data. We had a syphilis summit. Luckily, we invited the right people. We had ARPQC. We initiated it, did the pilot. And now we have Arkansas Medicaid involved, and now they're doing performance measures. So I just want to show that the littlest step can do not only things in the community, but also policy change. Next slide. And I could do a whole presentation on just our partners, because when I tell you I search high and low for these partners, it's because every partner needs to be connected. And there's still partners I don't know about that we're still trying to connect with. But we have the Arkansas Birthing Project, Arkansas Doulas, because doulas are a big support system in the testing world. And we actually saw one of our doulas at a maternal health summit, and she had no idea that there was supposed to be testing and treatment during syphilis. So I saw a knowledge gap, and then we started partnering with them. Again, the Armor, we also have incorporated the syndemic approach with our HIV group. So we have the HPG planning group here in the state, and so we partner with them. Recently, we connected with the Arkansas Department of Corrections because we do have a lot of moms and their partners in and out of jail. So that was a big connection that we got. Right now, we're just meeting and kind of talking about what we can do for each other. We also have on our Senate steering committee a member of leadership at Blue Cross Blue Shield, was a private insurance company. We also have community health workers. We partnered with a college, and then we also partnered with one of our largest health system and their home visiting program. Next slide. So future endeavors, right? So we kind of talked about all the partners, some things we're doing, but we're still working hard. We're still doing provider education. I actually just met yesterday with our infectious disease doctor, and we are planning to do out in the community with him and some nurses to do some education. As well as take epidemiologists for the data aspect and things like that. And we hope to travel around the state, but we also don't want to just go to hospitals and clinics. We want to go to doulas. We want to go to pregnancy centers. We want to go to the harm reduction. I know I see in the chat some stuff about domestic violence and sex workers and stuff like that. So we want to get in all these avenues, and maybe the state health department is not the best avenue for that, but maybe one of our community-based organizations can go to those, partner with those individuals and then kind of do it, through us, but maybe we aren't the face of it. We are starting a congenital syphilis review board. So this is kind of like the maternal and mortality review board, where we're going to deep dive into these cases and these babies born with congenital syphilis. We started an internal perinatal disease group. And so basically anyone who works with perinatal data in the health department, we invited them to this meeting where we kind of talked about what we did, as well as or learn what other programs did. And from this internal meeting, we actually met with the McB program, which is a home visiting here in Arkansas, to kind of see what data they had. And another thing, we got WIC data, and we linked our data with WIC, and we saw that 60% of our moms are on WIC. So again, that's another avenue to team up with the WIC team and see how can we incorporate getting our moms tested and treated or educated through WIC. We're doing an ELR study. So one of the things that DIS and the program are interested in is when we get an ELR, so an electronic lab record, they want to know if the woman is pregnant. And most of the time it's not on the lab record, and they have to go into different avenues to figure out if the mom's pregnant. Well, if we just had the ELR and we had it pop up that they were pregnant, that's less time on the DIS and more time getting moms to testing or into treatment. And so what we found was so far that most of the time it is accompanied by a positive or negative pregnancy test, but the pregnancy status. So now we're trying to figure out how do we make sure those two labs get together in the same surveillance system. We're still figuring out how to do avenues and meet people where they are for treatment. And then we also go to conferences. Again, we're continuously setting up because we think this enhancing surveillance data is going to show us even more and be able to open up more opportunities for collaboration and issues that we're facing in Arkansas. And I put this in all bold because you got to keep talking about syphilis. I've been talking about syphilis nonstop since 2023, and you'll be surprised. I'll go out and I'll talk to an OBGYN, and they're like, oh yeah, I know what syphilis is, but we're good in Arkansas. And I'm like, no, we're not. And they have no idea. And, obviously we have a lot more issues in Arkansas, but I'll tell y'all, syphilis is easy to catch and treat. So if we can do that and get providers and the public to advocate for themselves, as well as providers testing and treating, that's one less thing we have to focus on. And then we can focus on things like maternal health or mental health and things that are really big, like social determinants of health. Next slide. So kind of my conclusion, right? There is so much more to figure out. I talk like we're doing a lot of stuff in Arkansas, but we still have so many questions and answers that we don't know yet. And I love to learn from other states as well, or if maybe something I said, you could be like, hey, you should do this. Totally open to things like that. Congenital syphilis is entirely preventable, but we have to act now. But Arkansas can provide kind of a roadmap of what we've been doing with community-driven and system-wide solutions. But at the end of the day, all states have to take this seriously, have to do and prioritize routine testing, early outreach, and coordinated care. And I like this, this meme with, Michael Scott, and it says you miss 100% of the shots you don't take. And like I said, if you think talking about syphilis for 3 years straight, everyone knows, they don't. And you got to get people to care. And you also got to find stories to care, because if you just sit there and give them data, that doesn't resonate with people. But if you find a story, because there are out there, of moms losing their babies or having adverse effects for something that's 100% preventable, you get on people's heartstrings and they start caring. At the end of the day, I'll end with this. It's time to make congenital syphilis once again a condition of the past. And I thank you so much for having me. Next slide.
Thanks, Mallory. That is so inspirational. I love that too. And so with that in mind of not missing any shots that you all want to take after this webinar, please let us know what is one of the first steps you want to take for syphilis in your state. I think Mallory You really highlighted, and one of the things that I think I loved about your presentation is just how you started small. Like it was just a matter of like sharing the data and linking it, and then it led to these policy changes, some of which are even broader and go extend beyond syphilis. And I'm sure that these partnerships are going to matter for many health conditions affecting moms and babies across Arkansas. Um, so yeah, folks, please share any first steps that you want to take for syphilis. We can go to the next slide while people are answering. Um,
Yeah, and
Mallory,
again, just as I said, there's many external partners, but you have to find your people inside, and get people on your team and advocating for you. So here are just a few of our thank yous. Next slide. And this is my real backbone. This is my team and my infectious disease section, and I really could not do this without them. And I just appreciate everything they did. So finding a good team is also good, and finding people as passionate as you really drive your mission. Next slide. And again, thank you. And I think the next slide we do have an internal dashboard, and there's a QR available for those who are interested. And that's all I have. And again, I thank you so much for allowing me to talk, because I will always talk about syphilis. I'm very passionate about this. And again, thank you all so much for putting this on.
thanks, Mallory. Thank you everyone for all of the engagement that you've put into the chat thus far and also in the Q&A box. I know various members of the team and CDC have been answering questions. And so we are rapidly reaching that portion. Next slide, if during this time, can folks please also fill out the evaluation poll for this session? But we're going to turn over to questions. We can go to the next slide. If you want the resources, please sign up for our newsletter. We'll be sharing the resources highlighted in this presentation, as well as additional ones across the STI network to be able to just keep folks aware and able to support STI prevention testing and treatment. And with that, we'll open it up for questions. I think starting with one that came in prior to the webinar, which is what community and clinic-based interventions most effectively raise treatment completion rates among pregnant women diagnosed with syphilis in high burden counties?
Yeah, and so that's a great question. And so I wish it was an easy answer, but it's a multi-layered strategy, right? You have to get community-based and clinic-based interventions. And that's kind of what I've talked about throughout the presentation, is figuring out who in your community and clinic can you get together and drive these. So again, one of the things is the point of care testing, because this universal screening will ensure more opportunities for identifying syphilis cases in pregnant women and initiating treatment as soon as possible. Louisiana did this, Arkansas is doing this, and I'm sure many other states. So that's kind of like the easier answer, but one of the biggest ones, as I kind of mentioned time and time again in presentation, is meeting people where they are. We see this in public health. There's multiple HIV prevention, TB prevention. A lot of people have already done this where they're meeting people where they are, and that has been successful. Back in the day, we did have nurses that went out, and when they went with the DIS and they'd go to a field visit, and if the mom was like, or whoever did not want to come in, they would just have the option to treat right there. So Louisiana actually, and I'll put this in the chat, Louisiana actually is doing this right now in their shot program. And so, and I can't really speak to Louisiana, but I know from presentations I've been on, they have had success. But not everyone can, have an entire strategy where they can go out and have the funds and resources to do this kind of work. So one of the things, again, that we're doing in Arkansas is identifying people who already have mobile vans, who are already going out in the community and can give shots, like nurses. There's a lot of avenues here in Arkansas where we're trying to identify the best place to partner with, to maybe just piggyback on what they're doing. Because I don't think it needs to be, invention of the wheel. You can just tack on what other people are doing. Because as I mentioned throughout this data, we have domestic violence, we have mental health issues, we have all drug substance use. So finding those partners is super important, and connecting and kind of tacking on to that.
Thanks, Melly. That's really helpful. And I think I'm going to tweak Tracy's question a little bit. Tracy had asked, have you considered working with your birthing hospitals on obtaining, I think this is obtaining data and the usefulness of point of care. Oh no, okay, got it. Have you considered working with your birthing hospitals on obtaining as point of care syphilis tests as well as their overall usefulness? And I think it sounds like you are, but maybe just speak broadly to how you all are getting those tests and coordinating and like what kind of data you're getting back to test, whether it's effective or not.
So at this point, we're not doing the birthing hospital's point of care testing. We're only doing local health unit testing. Or at two local health units that we picked for the high rate of maternal cases as well as syphilis cases in their area. But that's the next step, right? We are seeing positive results with getting these moms treatment because at least they get one, it depends on their stage, right? But we're seeing this kind of like relationship building that maybe we can get them back in, or we at least test them and can treat with one shot. And I know Louisiana has very high success, and they've kind of done it longer than we have, so they have some really good papers out. Now with the birthing hospital, that's kind of the next step, right? If we see that point of care testing is working, that is something we could do. Now the funding did come from our infectious disease branch, and so obviously that's always the question, the funding part. And unfortunately, we actually only can afford around 200 tests, so it is a smaller pilot. But again, it's better than doing nothing, right? Let's see if this is working. If it works, then that's a paper or a thing you could write to get more funding to prove it works. So again, better than doing nothing. So I encourage states to do that.
Yeah. And that's really key, I think, to like get that documentation. So to try and get more resources that can go into this. I know that that's like a pretty, I think we've saw throughout the chat over the course of people mentioning that it's hard to get tests, hard to get like the treatments and things, and that rationing that you also mentioned happening during the bison shortage. I'm trying to think of which question to go with next, but maybe while I'm thinking, a question that came up again from registration was if a mother was adequately treated for syphilis prior to getting pregnant and there is an adequate response to treatment documented, why would the baby be a possible case of congenital syphilis?
Right. So when I first heard that question, my first response is that baby would not be a congenital syphilis baby. But I need to look at the case record. I need to look at all the titers because the first thing I would ask was the mom adequately tested during pregnancy and there was no fourfold increase? Because if there was no fourfold increase, the baby would not be congenital syphilis. Now, I do want to just clarify that, and I'm sure most know that the CST surveillance definition is not a clinical diagnosis, and we use that for surveillance purposes. And just kind of put in everyone's ear that CST actually this year is voting on kind of a new congenital syphilis definition. It's obviously the same, but there is a few changes here and there with like the CF protein. So be on the lookout for that for the surveillance team members on this call. So.
And I think we have time for one more question. I know folks have been answering. So if you have answered or asked a question in the Q&A, some of your questions have already been answered in a written one. Someone asked, what do you offer partners to qualify for 340B?
So this is up to our infectious disease branch. And so it's kind of like you have to figure out an in-kind partnership of like what they can offer. So again, when we're working, for example, with the armor, they would need help with, kind of because they got funding for the mobile van and some staff, but of course the medicine and testing is expensive. And so Liverings at 340B it's still in the works. But basically, the reason we want to partner with them is because they're going out in the community and they can test and treat where places we can't. And so that's kind of, you can't just have anyone get 340 pricing. And again, that's kind of the infectious disease branch, kind of see who gets that and who doesn't. And it has to kind of be like a give and take of like, us give this to you, what can you provide us, and how do we work together for a common goal?
Great. And I guess maybe one more question that you answered. You're very good at answering the questions. So someone in the chat said, my family is from Arkansas, so I have a special affinity for the state. But I have to ask, Arkansas has the fourth highest maternal mortality rate and the third highest infant mortality rate in the nation, and it has preterm birth rate of 12.1%. How does the state align those stats with finding success with syphilis testing?
So again, when I'm talking about syphilis testing, this is what's going to happen. We get a mom in, we test her, we treat her, and then hopefully treat their partner, and then we focus on what else is going on, mental health issues. Her, is she have preeclampsia? Do the workup on that, and then we can kind of focus on making sure she's getting the prenatal care visits to, maybe stop the preterm birth. And so that's kind of what our idea is, right? The syphilis part is the easy part. We got to get these moms in. Well, I say easy, but it's not easy, right? Like it's kind of a loaded answer of it's easy, but it's not. But getting these moms in, getting them treated, getting them tested, and then being able to focus on everything else that's going on but what we don't want is what's happening is we have all these other maternal health issues going on, but we're also focusing on syphilis. So maybe we did get everything else under control, but then the mom had a baby born with congenital syphilis because we weren't tested and treating.
Great. And I think go ahead, Jen.
I was just going to say, I think that's really great, Mallory. And I think there's something about normalizing and routinizing these tests so that, and laws are going that way, but then doing that in terms of implementation, making sure that everyone can get in, everyone gets screened and tested, right? It becomes normalized. And so then I think the stigma around this could also be diminished, because I think we're really, really careful not to, and I think that's where we're really careful about, highlighting some sort of random individual behavior when we know that the driving force is these structural, systematic barriers that are not, either they can't get access to care or they don't want to access care because of a multitude of factors. So just thank you for that.
Well, we have reached our time. Thank you so much, Mallory, for giving this presentation and sharing your wisdom and insights from Arkansas with us. It really is great to hear about the work that you are doing and the strides that you are making. And to know that it can be done in places like that are smaller, that have more rural communities. I know that there are a lot of places in the country that really have those same challenges. And so it's great to see what you're doing with the little that you have. And it's great to see those investments being carried forward.
Yes, thank y'all so much again.
And thanks everyone for coming. Just a note that Emma has dropped in the feedback survey, so please answer if you have time, and we will see you again soon.